What's going on, guys? Welcome to another nursing debriefing. This time we're in two different locations. I am on my fun employment, enjoying my nurse break. Peter's out in San Diego working and extending on his contract. So we're going to talk about Peter's experiences on his past couple shifts this week, and I'll kind of chime in and give my 2 cents on how he's been doing. How you doing, Pete?
I'm doing great, man. Thank you for asking. I'm actually looking forward to the San Diego summer because when we always travel together, or even when we vacation, we're always in San Diego, usually in like the April, May, June time. So we never experience like an actual summer in San Diego. We're always here in like the springtime for the most part. So I'm actually looking forward to having an actual summer in San Diego. But low-key, the last, I want to say 8 shifts, besides the 2 last ones that I just did, so 8 prior to the last 2, I was just been floating. I've been floating literally everywhere, and what makes it even worse is that I've been floating again at 11. So roughly 6 to 8 shifts in a row, I've been floating when I got to work, and then again at 11. So I've been having about anywhere from 6 to 9 patients a shift, which kind of sucks, but it is what it is. It's not the worst thing in the world. The nursing staff it makes it tolerable. It sucks floating, but when you have good resources and you have good team members, it makes it a lot more enjoyable, you could say. But
just like the teamwork makes the dream work, right? So it really does. It makes a difference. And even though you're on having 5 patients plus a night, it's still smooth sailing because of that.
Yes, exactly, 100%. And the thing is, I feel like a lot of nurses are scared to leave the unit that they're working on, even though it's like toxic or might be a little bit more heavier than they would like it to be. They're scared to leave it. I just want to let everybody know that if you want to try a different unit or try something new in nursing, like, go for it. You could always come back. I know we mentioned that a few times in our debriefings and in our podcast episodes, but you can always come back to your unit. Let's say your unit's kind of stressful right now, you're thinking about going somewhere else, or you've been thinking about it for a while, except you're not as committed as you want it to be. Just go ahead and leave. And let's just say the next job you have, it's worse than the one that you left, you can always go back. There's always a nursing shortage. Every unit is looking for nurses. I haven't been in a single unit where it's been staffed. Even my staffed unit, we were still pulling a lot of resources and nurses from the float pool and from the outside. So there is a minute amount of fully staffed units. So if you're scared to leave, just go ahead and leave. But I had a very interesting case, and this was actually in the ICU when I was actually in ICU my last shift. We had a patient. He doesn't really have a history of anxiety, but he is a pretty big gambler. And what happened was he went outpatient for colonoscopy, and post the procedure, he went into our A-FIB RVR. So I sent him to our hospital, and then in our hospital, he went to the ER, and then he went to a step-down unit. They couldn't really put his A-FIB RVR in control, so they sent him to the ICU, where then they did a TEE and a cardioversion. So we did a TEE to make sure that there's no blood clots or anything going on with his heart that's going to get complicated when we do the cardioversion. So he got cardioverted, everything was going good, and then he got super stressed about he had like lottery tickets or some kind of gambling stuff that he brought to the hospital, but then he lost it somewhere in his hospital stay. So he got really anxious, and then he went from signs with them all the way back to A-FIB RVR. So it kind of reminded me how important the mind is to the body, because he was fine, but then as soon as he worked himself up about this lottery thing, this whole gambling thing, he went back into A-FIB RVR. So imagine a person that's always stressing over things. Imagine how big of an effect that has to the rest of the body. You're not gonna maybe throw yourself into A-FIB RVR, but you might throw yourself into like a controlled A-FIB every time you get anxious. You wouldn't really know about it, because if it's a controlled A-FIB, your heart rate's like 80s to 100s. It's still at a decent rate where you're not going to feel like it's racing. You're going to feel normal, but you're still in A-FIB. So it's just crazy how the mind affects the body. And I'm sure you've had a few occurrences where you could attest to that as well with your patient experiences.
Definitely. Even when I was a staff nurse, there was a nurse that was pregnant, and her husband came into the hospital for A-FIB RVR because he was stressed out financially with work, with the baby coming, and he just went into A-FIB RVR. So it just shows you that it's more than just the heart, the cardiovascular system, and these systems that we have. It's actually the whole mind, body, spirit, like we always talk about, that has to do with everything.
Yeah, it's cool that you brought up the pregnancy part, because now I'm thinking, if the woman is stressed being a nurse at work and she's pregnant, I wonder how that affects the child, right? Because when you go to like the gynecologist and an OB doctor, they always say, hey, when you're pregnant, lower your stress. But then if you have nurses that are still super stressed at work and they're pregnant, I wonder what kind of effect that has on their offspring. And look how many nurses that we know that are trying to have kids and they can't, right?
Yeah, a lot of perspectives there, definitely. That would be a There has to be a lot of more research into nursing, right? I love to talk about it as far as changing healthcare, but you bring up a good point because yes, like what's happening with nurses as far as they being stressed out and how is it affecting the child. I wonder if there's like a longitudinal study we can have where they're growing up, are they more anxious or do they have ADHD? Because technically when you're conceived, it's like you're putting a energetic blueprint onto the child and everything carries over, not only nutrition wise but only psychological and energetically. So yeah, there's definitely some correlation.
Yeah, 100%. And my other patient in ICU, I haven't seen this for a while, but he had bilateral nephrostomy tubes. So this guy had a history of hydronephrosis, and what's interesting is that 6 months ago, his physician, his nephrologist, was thinking to put in nephrostomy tubes to begin with because he was having chronic urinary retention and kept getting UTIs. So 6 months ago, the doctor was thinking about putting these nephrostomy tubes in, and they just delayed it, and he ended up coming in for urosepsis and getting those placed anyway. So it's just like sometimes with healthcare, it's interesting because we know what to do, but we don't always know when to do it, for example. Because what happened was this guy probably he came in for a fall and urosepsis. So what probably happened was chronic urinary retention, got a UTI, probably got confused, and probably fell at home. That's probably what happened. Could have this been avoided? Most likely, if the physician would have placed him on the nephrostomy tubes 6 months ago, like he kind of envisioned that he needed them, but he kind of delayed it because nephrostomy tubes, that requires like a pretty big lifestyle change. So for nephrostomy tubes, for those of you that haven't experienced nephrostomy tubes, instead of the urine going into your bladder, you literally have these tubes placed into like your I'm not sure, I forget what those vessels are called, but
your flank,
your flanks, yeah,
body,
yeah, and basically instead of your kidneys draining urine into your bladder, they basically drain it through these tubes into these bags. So it's like you almost have bilateral Foley bags, for example. So
yeah, quality of life.
Yeah. So it's a big lifestyle change. So I understand why they kind of delayed it, but if the doctor would have placed it sooner, you probably could have avoided this whole issue and spending a week in a hospital now. But it's medicine, so not everyone's the same. Like I said, it's a big lifestyle change. So it's not like the physician's fault that this happened, because as a physician, you want to maintain autonomy for as long as you can, and this was the best route. And you also had a PICC line that we're trying to pull. And he gave him a little bit of patient education because he wants to leave it in, because he knew that was for blood draws and medications, but he didn't want to get poked. And I had to do a whole education that it sucks getting poked, but we don't want to leave these central lines in you for a long time because they're basically going to your heart, and if something were to happen, you're high risk of infection. So all that kind of patient teaching. So this basically these couple of shifts, I've just been floating, literally being an RN, refreshments and narcotics, and these couple of days in ICU, which I found some decent stuff, but I stepped down patients.
I'm kind of smirking because I've been away from the game for 3 weeks now, and it's like same shit, different day. There's always something going on, or floating, or there's always something going on with patients. So healthcare is just like an ever revolving door of just stories and stress and the fun stuff of healthcare, man. I do miss it a bit. So just kind of going on a shift and seeing what's up, because it's been such a different experience being on my nurse break. But I'm thinking if I'm going to be off for 3 months, I probably should pick up a job to do per diem. So I've been kind of debating between...
Do you though? Right.
Last year I took 3 months off, and it wasn't too bad going back to work. That's when we went to Austin. So I mean, I just picked up pretty quick. I kind of want to do it just so I could share some stuff with you too, to be honest. Kind of shoot the shit about what's going on in healthcare on the other side of the country. So I have two options. I could probably get a job per diem through a hospital, but just like you're doing travel nursing, I could probably find a agency here that I could just pick up a quick contract whenever I want to and just go work. So probably less politics, probably less orientation. So I saw some jobs on LinkedIn, and I think maybe this week I'll see if I could get something going with that.
Yeah, there you go. I mean, I still have that in Oak Lawn if you want to do that, but you want to do like a contract though, right? Not just it would be like a contract thing, right?
I'm looking for a peer DM. Like just like you said, I really want to enjoy my nurse break. I don't want to work. I don't want to even work 20 hours a week. If I could pick up one shift every 2 weeks, I'll be satisfied with that. Because the money is not what's pulling me. It's just me necessarily just maintaining my skills and me contributing to the podcast or these debriefings talking about healthcare in Chicago, basically.
But what I'm thinking is, because you brought up, you mentioned when we were talking, or yesterday or the day before, like case studies. We could always do some case studies if you don't feel like going back to work or whatever. We could just do some case studies here, present the rationales, all that nursing school stuff.
Thank you for giving me the blessing of not going back to work, man.
Because it's rough, and like when I look back at it, I'd like to do the 3-month break, but I just didn't want to this time around. I don't know why, but I wanted to stay in San Diego. That's why, low key.
Yeah, man, enjoy. Go some surfing, do some beach there.
100%. Yeah. So another debriefing here in San Diego. Wonderful time at this hospital, wonderful staff. Oh, real quick before I go, one thing I want to mention for all nurses that are non-ICU, so tele, step down, oncology, all that kind of stuff, because we had a interesting case that happened. So a patient came in for I don't know if it was an ileostomy or colonoscopy reversal, but he came in for that. They did the procedure, and he wasn't looking too hot after the surgery, but they sent him to the floor. I'm not sure if it was tele or med surg. I didn't look too much into details, but what happened was the patient ended up coding, and one of the RTs, the RT nurse, the rapid response team nurse, was looking through her chart and everything, and the patient was looking bad on the floor, but nobody said anything. Whoever was the nurse didn't say anything that he was decompensating, so things didn't get addressed in a timely manner. And they didn't get addressed in a timely manner, and when they did get addressed, the patient ended up coding and then got brought up to the ICU and ended up passing away. So I just want to let everybody know like the importance of just speaking up. And if you, even though you're wrong, you may think your patient is not doing the best or they're slowly deteriorating. Maybe it's not a big deterioration, but just slowly declining, and you're kind of thinking, hey, are they doing worse? I'm not really sure. Just ask your chargers, ask somebody, because you could prevent these kind of situations. Because just looking back at the notes, even though we didn't speak to the nurse or the charge nurse on the floor, just by looking back at the notes and the charting, you could see the decline of the patient, the vitals dropping, mentation becoming an issue, the patient started getting confused, all that kind of stuff, and didn't get addressed, unfortunately, until the patient coded. So if you have any kind of gut feeling that maybe there's something off about your patient, speak up. It doesn't matter where you are. Like, for example, one time I didn't speak up, and I felt like the patient abdomen was being distended more and more and more, because I noticed the progression through my shift, especially when I first assessed them around like 7 p.m. and then I reassessed them again with the oncoming nurse at around 7:30 in the morning, so 12 hours or whatever. I saw the change in his abdomen, and I thought, and my gut told me that, hey, is there an obstruction going on, because there's still bowel sounds and stuff like that, but it was just got more and more distended, and I didn't bring it up because I thought nothing of it, even though my gut instinct was telling me, hey, there's probably something going on. I was like, no, it's probably not a big deal. You probably had something for lunch. And he's probably just gassed up. And next day, I come in, I get the patient back in ICU, and they're saying, yeah, he's got an ileus or something like that. I forgot exactly what it was. So, we're nurses. We obviously can't catch every single thing. But if your gut instinct is telling you something about your patient, just ask somebody about it, tell somebody about it, tell the oncoming shift, just so it gets addressed. Like, it happens to the best of us. Sometimes we don't listen to our intuition, and it kind of is what it is.
You bring up a great point. And if it's not your intuition, sometimes we don't like to speak up, coming from some med-surg experience, because what is the ICU nurse going to say anyway? So when that RT nurse comes in, you know how there's cases where the ICU nurses are laughing at the floor nurses because, oh, they called up for this, or nothing's really going on. And sometimes there's like this intimidation where the med-surg nurse doesn't want to speak up because, well, maybe this is not a big deal, but it's okay. Like, we're advocating for the patient here, and this is the other side of the perspective. If it's not your intuition, speak up. Doesn't matter what anybody says, do it for the patient.
Yeah, exactly. 100% agree with it. And even when I was orientating nurses, back when I used to work staff in Illinois, asking questions almost differentiates a good nurse from like a great nurse. because I orientate some nurses that they would ask questions about everything. And even though some questions were kind of like, she probably could have thought about that a little bit and probably could have figured out herself, but at least appreciated them asking those questions. And there was those times where I would ask a nurse a question, she'd respond, or she would assess a patient, and she would do her thing, and I could tell she's got a question to ask, but she doesn't want to ask it. They look a little bit confused or whatever, so now I would be like, hey, do you want to ask me anything? Like, is there anything on your mind? If I have to facilitate a question, that's usually when I tell the nurse, like, hey, when you're going to be working here in ICU, like, you have to ask questions. If you're not sure, you have to ask questions. Because especially at the place I worked at before, when I was staff in Illinois, people deteriorated super, super quick. So if you didn't get someone addressed within like a 20-minute time frame, you were putting yourself in a bad spot. So I would always push emphasis of, if you're not sure what's going on, ask, because people could just drop for no reason. Like, for example, I remember when I had a patient in a chair when I used to work in Illinois, and he was an LVAD patient, and his MAP was 100. It was like 105 or something like that, and he's hypertensive. So I left the room, talked to charge nurse, whatever, and I came back like an hour later. I'm like, okay, let's get you back in bed. I'm gonna give you blood pressure medication in like an hour. So I basically got busy chit-chatting with like a nurse about another patient, and I delayed giving my blood pressure medication by like an hour, for example. And then I got him up, and as soon as he stood up, he had a stroke on me. So it's nothing my fault, and he ended up dying or whatever. But it's just one of those things where you have to address these things in like a timely manner. It's not my fault that he died, but just one example. He was in a very bad state to begin with, so it was only months he had to live anyways. But it is what it is. So yeah. So just ask questions. Don't be afraid.
Great point to kind of cut off is the power of speaking up.
Yeah, exactly. So is what it is. But yeah, another amazing debriefing. We'll see you guys next week. Maybe Matt's gonna present a case study next week. We'll see how it goes here.
All right, peace, guys.